Welcome back to the second half of this morning's session. And for those of you who may have joined us from the break, my name is Jill Marcella, and I'm going to be your moderator this morning for this feedback session. So the previous session was on innovations in palliative care, a multifaceted exploration of education, community support, and scope achievement. Just a quick reminder for our audience online. Again, we invite you to share your thoughts and your questions. You can enter them into the chat, or if you would like to remain anonymous, the Q&A option. We also encourage you to join us in the conversation by putting your camera on. So Carol, great to see your face. I can see your face up there. It does provide a bit of a collaborative environment in here, and because this is feedback, and Kevin too, great, Natalie. Yay. I've had a challenge as a moderator we were presented a challenge this morning to have, because we're all in different rooms, which moderator is going to have the most amount of people on camera and joining in. So it's great to see some faces. Thank you.
Okay, wait, we want more faces though, Jill. We want lots of faces because we want to win this challenge. So the other two rooms and the other two sessions are doing something similar to this. And I have laid down the challenge for my staff to say that if we can get the most people to come on camera and take themselves off mute and join in the conversation, apparently I got to get a prize now. So we're going to do this, people. So our online, we have 22 people online. Gloria, lovely face. Love to see you, Gloria. We are going to rely on you guys to help stimulate the conversation as well. Take it away, Jill.
Great. And then just a quick reminder for those of us in the room, if you have questions or comments, the mics are in the middle of the room. Also, you can raise your hand and someone will come around and bring you the mic. The importance of that, so that the people online can hear what your questions or your comments are. So just a quick summary of this morning's panel presentation if you weren't here in the room or online. In the previous session, the panel speakers provided a really great starting point for the conversation and that we're about to engage in, and shared their knowledge and wisdom with all of us, as well as providing us with some of their promising practices and innovations that are happening across Canada in palliative care for Indigenous people. So first, the panel started with Holly talking about some of the curriculum that's available through Lakehead University. We've got a curriculum for palliative care for frontline workers in Indigenous communities. There's a curriculum that's specific to caregivers and community members who would like to support caregivers in communities. So there's free resources, presentations, and slide decks. There's also the enhanced guide for LEAP, which is the curriculum that's developed by Palliative. And this enhanced care guide is really or delivery guide is really supporting the delivery of that LEAP education in a culturally appropriate way. So it really has a different type of facilitated approach. And then we also had Joanna talking about supporting the journey home, growing the care bundle to care for those with serious illness. And Joanna talked about that it's an Ontario-based curriculum right now. They're both online and live sessions, and it happens over 12 weeks. And they use videos, case studies, and guidelines, and really focusing and realizing that the start of these conversations need to happen when an individual is diagnosed with a serious illness versus when they're maybe at the end, last 6 weeks, or 6 months, or year of life, or end of life. And then really also using those circle reflections and 7-day assignments as part of the learning. And that's really that curriculum's way of incorporating practice or what is being learned into practice. And then also having guide sheets and resources for participants. And then Sue and Joanne talked about the Indigenous End-of-Life course that's offered in BC, a 4-day course that really looks at the cultural and traditional protocols, the palliative approach to care, honoring your wishes, supporting grief and loss, and some self-care, and also using the approach of the elder and residents being part of the delivery of that education. So the purpose of this feedback session is part of to provide everyone with an opportunity to share what your latest happenings in your communities, your organizations, and and within your teams as well in relation to the topics that we've covered this morning. So whether you're from an Indigenous community or working in a space as an ally, you're working within a team, we want to create an environment where people are learning from one another, not just from the speakers. So we also want to help build new partnerships and connections, create synergies, share our resources, and promising our innovative practices that are making a difference in your communities and in your teams. So this is a chance to discuss the challenges that you're facing, to highlight the strengths that deserve recognition, and perhaps come away with one or two recommendations or strategies that you might be able to implement and practice right away or to create change. We hope that you leave the session with fresh ideas and inspiration to help improve care in your communities. So the session is going to be facilitated through some questions that are going to be posed to the participants using Menti. We went through and used Menti yesterday. And then we're going to open it up to a discussion. So we'll start with the Menti question that I will ask everyone in the room and online to complete. And once completed, I'll go through some of the responses that have been received. And then we'll open it up and explore further questions or comments. So I'd like to take a moment to reintroduce you to Menti. So for those of you in the line, I already see you've taken out your cell phones. You can scan the QR code on the screen. You're going to open up your camera, point it to the QR code. Once you can see the QR square, there'll be a little yellow lettering that says menti.com. You can tap on that, and it will bring you to the menti.com site, and a link will open. For those of you online, you can use the same process on your computer screen, using your phone, going to the QR code, or you can click on the link that's provided in the chat, and it will bring you to the Menti webpage. So everyone should arrive at the webpage where you can answer the first question on the screen. You can submit several ways to each question. To do this, please type in your first answer in the box. Then you're going to scroll down to the bottom and click Submit. Another box will pop up, and you can add another answer. So as we're doing this, if you would like to continue to provide additional answers to your first one, you're going to use the same process. So entering an answer in the box, scrolling down, hitting Submit, and then it will come back up to the box with the same question, and you can continue to do that until you're finished with your answers. And then once you're finished answering, you'll scroll to the bottom and click Next Question. Once you click Next Question, don't close your web browser, because the next question will automatically come up, and then we'll move on to the next question. And so to begin, I want you to think, as we begin with our first question, what I want you to think about right now is the educational needs of your healthcare providers, community members, and family caregivers. What types of education are needed? How is that education accessed? Is it culturally appropriate? So we're going to take a look at our first Menti question, and I want everyone in the room and online to answer. What challenges or barriers does your community team experience? So this is in relation to when it comes to education and training healthcare providers, community caregivers, family members who are caring for Indigenous people at the end of life or journeying back to the spirit world. So this might have to do with access to culturally appropriate and relevant education. Maybe your team members don't have the appropriate skills or the training. It could be a geographic issue or barrier. Might be unreliable internet, unreliable service provision, cost. So those are the types of things you might want to be thinking about.
So I just want to check, everyone in the room okay? You guys all got it? We see the answers coming up on screen. Good. Okay, take it away, Jill.
Great. So we've got 30 responses so far. I'm just seeing, are we up? No. And so some of those challenges and barriers, it looks like physical distances between communities is one. Actually, several: lack of resources and turnover, lack of resources, period, short-staffed, access to community-level education, apprehension towards talking about end of life and death, family inclusion, budget for the service provision, staff turnover time, releasing providers to engage in the training. That's a big one. A lot of people don't have backfill. The workload, again, high turnover rate of frontline staff, distance, funding, engagement, systemic racism within the healthcare system. Healthcare providers are too busy, competing priorities. The stigma around palliative care, we often hear that. There continues to be a large stigma around palliative and end-of-life care, thinking that it's focusing on death and dying, and missing that it is really supporting all of those areas of a person's quality of life. Culturally appropriate, whether or not it's culturally appropriate. The current education that is offered may not be culturally safe. Few Indigenous staff in the health region, opportunities for in-person training and reallocation of frontline staff to be able to fill in. Medical language and English as a second language. The time and cost associated with the training in the community. And that community members' primary focus and concern about safety and community. So again, I think that's about the priorities that are prevalent in the community at the time. And then workload. So these are some of the challenges and barriers that you've identified through the question, and I'd now like to just take an opportunity to ask our panelists, from the experiences that you've had in delivering your curriculum, what you've seen as some of those barriers or challenges are.
I think one of well, it could be both a barrier and a challenge, is that we don't look at our children and infants needing palliative care. How do we, and the other thing too is that, we know that we are going to leave this earth one time or another, and it's not a common discussion in our communities, and we need to be able to engage in positive discussions and advancing, like, how do we prepare for when we need that special care or when we're aging out. We often don't prepare ourselves until we reach a crisis. Then everybody's in rush mode to solve the problem or show their support. But I think with more education, more programs, and including all ages, would help our nations flourish in a good way and address, because death in our life, we're given birth, we live, and then we prepare for our final journey. That's in our culture. Mm-hmm. But we just want to live right now and just for this moment, but we don't think about what's going to happen tomorrow or right now.
Thank you, Joanne. And thank you for bringing up pediatrics, because I think that's an area that we didn't touch on so much this morning in the overviews, but I think is a very, very important area that's a barrier or a challenge in communities.
Yeah, and I think we talked about some of them today, this morning, staff retention and recruitment. We're having to constantly retrain healthcare providers over and over again because of that. It's a huge challenge. As we know, as many people have said, funding, to have sustainable funding. So for myself and my team, I'm always looking for the next funder to be able to deliver this education. We know this education is needed. We just got to get the word out there in terms of how are we going to support that and what is it going to look like. And I just want to give everyone the heads up. I'm performing double duty, so I'm doing the mentee, so I'm going to jump back and forth, which is why I just jumped up here. But, okay.
And Sue, do you have thoughts around some of those challenges and barriers?
Yeah, I agree with the list that came in. We see that all the time, all those different areas. I think I'm thinking about just this last course that we just taught, and it was so profound, the depth of grief. And a barrier in terms of, and the challenge of how do we help support communities to lift that grief, and give time and space for that work. Because we see that if people don't cope with the grief, then they reach for maybe some unhealthy coping support, so we continue cycles of harm, and we'd love to see more work with grief. From our survey and evaluation, one of the messages that we heard was around supporting grief and loss, but another one was, how do we have paid support for people, those natural helpers, to be able to continue to do the work, because it's hard for them to prioritize to do that work and yet still be okay with their living and their costs and of life. So looking for some funding to support those natural caregivers too.
Great, thank you. I think those are great additions to what was provided online. Now, I'd just like to open it up to those of you online. If there's anything in addition that maybe you didn't see was covered, or something you'd like to share as that might be unique to your community or within your team. So if you would like to take yourself off mute or raise your hand, I can invite you at this time.
Can you guys hear us? Just checking. Kevin. Kevin, we can always count on you, Kevin. Come on, Kevin, give us some of your challenges in educating the Métis Nation within Ontario.
Hi, Holly, great to see you. I want to thank Glenn for what you said regarding the ageless approach to palliative care. It is so true that we do not spend enough time thinking about what it means when a youth or a child in our community needs that kind of care. And I really appreciate the fact that you brought it up. And the fact that you mentioned that it's almost a last-minute thought to provide palliative care, I think that's very important too. I just recently retired after 12 years as chronic care coordinator with a team of PSWs and RPNs. And we would often get a call from a family looking for support when they were at their wits' end and literally did not know what to do next. And so they would call and look for help. And I think that's very important to remember, is that they weren't taught. They were not schooled by their aunties and their cocoa. They didn't know what to do. And so they sought outside help. And equipping our communities, teaching those lessons that have been lost, the generational lessons that have been lost, that's where we're starting with the Métis Nation. And thank you for the opportunity to be here. It's an amazing conference.
Miigwech.
Thanks, Kevin. And then in the room, any additional thoughts?
Challenges around education.
Challenges, things you'd like to share with the group that weren't captured?
Or that you would like to elaborate on. And again, even if you're not an Indigenous organization, but as an ally, what does that look like? And I'm going to call upon Shelley Corey, because I like calling upon people. That's part of great facilitation. Shelley, can you tell us about some of the challenges that the Canadian Virtual Hospice has experienced when it comes to providing education for Indigenous peoples around palliative care?
Well, maybe if I can thank you, Holly, for calling me out. I kept thinking,
Nobody is safe. Nobody is safe.
Should I jump to the mic or not? So we have been incredibly fortunate and grateful to be working with Holly, with Joanna Vautour, with an Elders and Knowledge Carrier Circle that we convene. And this is a national Elders and Knowledge Carrier Circle of First Nations, Inuit, and Métis elders who come together, help us set priorities for developing education materials, and also inform all those materials. So we have, I think you've seen Coming Full Circle, which is a pre-advanced care planning document that we have. We've heard some discussion about whether there should be an umbrella of whether it's appropriate to have a tool that applies equally to First Nations, Inuit, and Métis. Our Elder Circle indicated that that was appropriate when they looked at the materials. I think that's still a challenge that we're facing, because and I've heard at this conference that some materials that are created not necessarily ours, but generally. If they're not nation-specific, then there's a challenge. One of the things, a huge thing for us, I think, is getting the resources embedded in community. How do you reach out? We know that the communities who access these materials love them. So First Nations Health Authority, we've got a partnership with First Nations Health Authority who co-brands our Coming Full Circle document. And so it's going out, there's hundreds and hundreds of these going out. So we know it's effective. We know that people are embracing this document that was developed again by Holly and elders, but not everybody knows about it. So it's creating, how do we create those partnerships? Because often we find with our grants, the grants are there to create the products, but they're not necessarily there to do the long-term embedding. So it's not necessarily enough to say you're raising awareness. You really have to embed some of these products in practice. So how do we do that? How do we do that creatively? And also, how do we get feedback? So everything that we're doing is online, which is incredibly difficult, let me tell you. I mean, it sounds really easy, you throw something up online, but it's hard to get feedback from people. So everybody tells us things are great, but I'd love to hear from the people who are saying, you know, I think this needs to be fixed or that needs to be fixed. Since Holly's given me the microphone, and she'll learn not to pick on me again, because now that she's given me the microphone, I've got it, right? So the other thing we have is Indigenous cultural safety training. And it's online. There's 5 modules. 2 of the grief modules have been developed by Joanna Vautour. The other 3 modules have been developed by Holly and the elders. They're terrific. Again, they've been embedded by the Quebec government, which has been a real coup for us, because usually the Quebec government doesn't accept a product that's been developed outside of Quebec. They are vastly popular, but again, it's how do we get the word out to communities? How do we get the word out to the broader healthcare system that these are available? They're free, they're evidence informed, they're all based, they're Indigenous developed. But we need the opportunity to, like this, to make people more aware of them. So I guess for us, it's awareness. And feedback is huge, and the ability. There's so many suggestions, recommendations that the elders have made, and there's just not enough funding to do everything that we need to do. So making sure that how do we reduce duplication? How can we work together to pool our resources to develop content? And I know it's not always possible, but where it's possible, how can we do that so we can do more with the money that's out there? Thank you.
Thanks, Shelley. And your point really too with the online resources, I know what we often hear, people still really want things in print, and so much now is done online. And in some of those, I would say, remote communities or rural communities, especially for the healthcare providers, having that print resource to be able to take along with you to the visit is so important, and not having them accessible in print can sometimes be a barrier or challenge.
So I think we have a question online, and I'm just wondering, I'm going to put it out there to that person who put it online. Would you like to take yourself off mute and maybe just ask your question?
Yes, please, Michelle.
Yeah, Michelle. We got 2, Jill. We're going to win this challenge. Awesome. So I'm just going to say for your second part of your question, when you're asking about recommendations, we're actually going to have a mentee question that's going to talk specifically about recommendations, Michelle. So we're going to hold that. But I'm going to put it out to the room. Anyone know if there's mandatory
Cultural safety
training embedded within, say, physicians, nurses? Go ahead, Nicole.
Hi, everyone. Hello. Hi, everyone. I'm Nicole Wakegeorge from First Nations Health Authority and clinical nurse specialist, and supported this program, letting the lovely ladies who are facilitating talk about the program. But in BC, racism is rampant throughout Canada. But a couple years ago, our government did a report called In Plain Sight, and that's available online, which did demonstrate racism was rampant. But as a result of that, there are mandatory standards for both nurses and physicians for their college about being culturally safe and practicing in an anti-Indigenous racism and trauma-informed practice. So in addition to that, there are HSO standards that First Nations Health Authority developed. It wasn't me, others in our organization, so that organizations who are wanting to have accreditation have cultural safety and humility standards. So those are kind of like the high level, and then it's coming from the college. It's also coming in BC for all other regulated health professionals, whether they're a physio or a dentist. And then as far as the mandatory cultural safety and humility training, it depends on where you work. But one of the things, we have a provincial program right now that some places make mandatory, but there is a fee for it. And they're looking at revising it because within the course, which is online and collaborative and facilitated, there was racist remarks within the participants of the course. So it's not meeting the needs of what people need to practice in culturally safer ways for the people that are wanting to get care. And so we know that racism is still a barrier and people still don't go and get care because of the racism they've received in the past. So I hope that helps. But I actually do promote the ICS training that's available online because it's free, and I know talk to many hospice societies across BC to let them know that that is available and free, and they're lovely. I love the courses. So great. Kudos to Shelley and those that helped develop it.
Great. Thank you. So we're going to move on to question 2, and it's going to come up again. Hopefully your link has been opened in your Menti. And the next question is, what strengths and capacities exist within your community or your community team? So when thinking about when it comes to educating and training healthcare providers, community caregivers, and family members who are caring for Indigenous people at the end of life or in their preparation for journeying back to the spirit world.
Yeah, so if you can keep your strengths and capacities really focused on education. So what are your strengths and capacities in educating and training healthcare providers, community caregivers, and family members? And there we go.
So we've got our first response. So strength being people with a strong desire to learn how to provide care with dignity. A strength is the commitment, wanting and actively unlearning and learning. We're able to educate nurses, unregulated, and community members. Emotions can act as a strong motivator to access and search and obtain education, being part of the community, those strong multidisciplinary relationships, having a national network of experts and facilitators who are passionate about the education, improving care, hospital foundation funding and training. All staff have the worldview that learning occurs continuously, wanting to share resources and continue learning, passionate about the care provided, Passionate, determined people. I have to say that's one thing we often find in palliative care. There is a lot of passion and commitment. We have annual funding for healthcare staff and palliative care education, healthcare providers and community members working as a team, grandmothers who generously share and teach, focus on loss of traditional familial supports and how to support clients as well as their families when providing care and resources. There's a large interest in wanting to storytell and share experiences to shape future care and wanting change. Having Indigenous community members in the position of healthcare providers, commitments within the communities, the experienced frontline staff with a variety of knowledge and approaches, sharing learning experiences with coworkers, clients, and family, the will to provide the best care possible to community members, people with lived experience, staff that have training and budgets, as well as I'm thinking maybe clinical support underneath. And then, unfortunately, lots of lived experiences with palliation and family community members, train the trainer models which have a ripple effect to family and caregivers. This is essential to client-centered care. And staff are committed to community people, and people want to know cultural knowledge. So I'll open it up now, maybe back to those of you online, and ask first I'm doing it in the opposite. I want to open it up to our panelists. So when it comes to those strengths and capacities that exist within your community and your community teams and what you've seen when you've been providing education, what have some of those been?
I think for us, a big, I would say, strength, again, is that it's Indigenous-led and designed. I think another big strength, but it's also kind of a challenge at the same point, is Indigenous facilitator retention and recruitment. So finding Indigenous social workers and nurses who are interested in palliative care, mentoring them to be a part of this space, so that we can then train them to go back to communities to deliver this education. And I think as Joanne was saying, really having those elders and those knowledge carriers a part of it. I don't think our education would be as successful. I don't even think it would be successful if it wasn't for the great group of elders and knowledge carriers that I work with. They are amazing. I have worked with elders from right across Turtle Island, and they're willing and able to share their knowledge and teachings with Indigenous peoples, because we are in a process of reclaiming and relearning, but also with non-Indigenous peoples. And creating that space to have those questions that maybe they're a little bit nervous to ask. So I think, as Joanne was talking about earlier, that two-eyed seeing approach is really great, but also recognizing that it is for Indigenous peoples.
Thank you. I think that's really adequate because, we look at Indigenous people and we kind of categorize, but then we have to be inclusive and we have to educate and share because we all have that common goal of making that person comfortable. Or how do we support the family? And it's not over once the person's passed. Our job continues because, and I think one of the challenges that I see, and it could be a blessing at the same time, is that we acknowledge those cultural and spiritual people because they are the PhDs in our community, and they should be recognized as such. And having that balance of both the clinical and the cultural components working together has created a good rapport and advanced education in the end of Indigenous life. I think they need to be a really good balance. And the other thing that I think is a challenge is that how do we recognize, and when we get those educations, those degrees and a master's and that, how do we acknowledge our knowledge keepers as PhD people in our community? And I think that's something that's a challenge that it's easily fixed, is allowing individuals in their communities, identifying those key people that hold that specific training, because it wasn't just 4 years that to get or 10 years for a doctorate. It's a lifelong process that individuals are taught to be knowledge keepers, spiritual people, and I think that we need to recognize that. Also, we can teach as many people as we want how to be advocates, but we have to secure the funding to make sure that we have people that can go provide those services in, whether it's at home or in an institution.
And I think, Joanne, when you're talking about recognizing them as PhDs, so one of the things, again, is I would say is a strength of what we do, is that when I'm asking an elder to be a part of my team to support that education, I am paying that elder the same thing that I'm paying that physician. I'm paying that elder the same thing that I'm paying that nurse and that social worker. So again, I'll say that for the next one because it's talking about strategies, but recognize that, like, to do this good and to do it well, you have to have that recognition of all the people that are involved in it. Sue, anything?
The only thing I can add, because I agree with everything that you've shared, is I see a real strength in the people that come to the courses and the passion that they bring and the commitment that they bring. But there's something that happens when more than one person from a community joins, and they have that support, and that it builds the confidence to take the work forward. And we're really seeing the magic in that. And we always end our class about, what do you commit to after this? And to hear, like, some people want to go political, some people want to go develop more resources, some people want to build support groups once a month. And so that's the power of bringing the group, the synergy of people coming together.
Right. Thanks. Opening it up to, I think, first those online. If we've got, we can bring up online. And if I can invite any of you online, what are some of maybe the strengths that you are seeing within your programs or your teams that you might like to share with us here in the room?
Don't make me shame you guys, because I will.
Is there anything that anyone online, if you're part of a palliative care team or community team that's supporting those that are seriously ill, that maybe is something unique to your community or within your team that you can share with us?
So Tracy, I'm going to call upon Tracy because Gerald came over to me during the little break and he said, call upon Tracy. So Tracy, in Saskatchewan, any strengths that you see in your organization or community when it comes to providing education, in particular for Indigenous communities or staff or families or caregivers? Is she there? It was Gerald. It was Gerald.
Thanks, Gerald. That's actually something we've been struggling with, and interestingly, our foundation has a little bit of funding to specifically target education regarding Indigenous palliative care, so it's something we're working on. We did recently build a hospice. It's called a hospice at Alberta, and we've created a beautiful ceremonial space that is being utilized by folks who have access to the hospice. And so we're pretty proud of being able to provide a proper space for ceremony. However, I think we still have challenges and need to learn a lot about the ways in which it might be appropriate or suitable for Indigenous people to access hospice. Because I know we talked a lot about people wanting to die at home. And so I think we have work to do there. On another note, we do have funding available also for folks to take part in LEAP training. But I think there probably needs to be some work done there too in terms of LEAP and that's specific, more culturally responsive. So I put the challenge out to Kathy on that one.
Miigwech, Tracy.
And what about those of you in the room? Is there anything you'd like to add?
Marjorie.
Marjorie?
I think for us, what I've seen in our communities is there is no hospice. If a person is palliative and is sent out of the community, sometimes very hard to get them back, and they end up dying away from their families. Another thing is, if they do come back, sometimes it's not always a safe place for them to come because there's a lot of overcrowding in homes. So I think there needs to be some work around that. And another thing is, with the training in that, sometimes family don't know their own worth and their value in how they can help with palliative care. They tend to shy away from it. Even though they want to help, they think that they may do something wrong. So I think it's just encouraging family and staff to work together more and give them more encouragement to make the wishes of the palliative patient come true.
Miigwech, Marjorie. And yeah, I think that is a huge strength, especially in Indigenous communities, recognizing this concept of kinship that we have in Indigenous communities, and recognizing the important role and valuing the important role that family and community caregivers have. Any other strengths? Oh, right
Hi,
there.
everyone. John Faulkner from Palliative. I just wanted to respond to the comments online and share a little bit of what we are doing. We play a bit of a unique role in the sense that we're a national organization. We're delivering hundreds of sessions a year, coast to coast to coast across the country. So we're not trying to fill that gap that, Holly, you and your team are filling, where you're going into community, you're going deep, you're doing those deep partnerships. Where we're able to support that is through the work like we do with you using LEAP in Sierra, other organizations using LEAP across the country in that sort of flexible, adapted approach, which is what we love to see. What we are doing, we've started some early stage partnerships, started in Newfoundland and Labrador, where we're building some, I will say regionalized, it's not quite the right word, but regionalized cultural safety and humility modules to support what's happening in LEAP. We're building them iteratively with partnerships across the country, where we can find adaptations to the communities when working with communities that are there. So we've got a structure that's flexible and allows us to then adapt that to different contexts, to different communities, to different settings. It's not going to be community specific. That's not something that's in our capability. We're trying to find that middle ground where we can reach the hundreds of thousands of healthcare providers who interact with Indigenous peoples across this country and give them some insights in how they can be better at providing culturally safe, culturally appropriate palliative care. So happy to talk to others about what we're doing there. But we started in Newfoundland and Labrador. We're adapting it for Alberta right now. We're looking at working on Ontario, or parts of Ontario, and we're just starting to explore PEI as well. So we're getting there.
Yeah, and I think that's really great, Jonathan, that you mentioned that, because again, there is a lot of education out there. People might not know what it is or who it's for or how to access it, but to recognize that I think people in this room, up to this point anyways, we're really trying to work collaboratively. So, the fact that we develop a tool to enhance some of that LEAP learning, to train facilitators, the fact that Sue and Joanne, work with the Canadian Virtual Hospice to co-design tools and resources, and I think with the limited amount of funding that's out there, perhaps, that's a really great opportunity.
Hi, so my name is Natalie DeFebo. I'm a program instructor with SE Health, the First Nation Inuit and Métis team, and I have a question with regards to information sharing, digital health information, and if there's anything in the education courses that you're providing with regards to strengthening our healthcare providers' ability to provide support with regards to how patients, caregivers, family members are communicating with acute health centers, palliative care units, and their health centers, perhaps on First Nation, Inuit, or Métis community settings.
Anybody in the room that might have experience in, that's a bit of an elephant in the room always,
I'm
isn't
sorry,
it?
yes,
The
it's just a
digital-
question
the
because it
digital
is an
health
elephant,
and how
and as is something that we all probably, as we navigate challenges with clients, caregivers, and transition in between, acute care and home, what that might look like, or any work that's being done in the education areas.
One thing that we have offered is because so many of our communities are remote and may not have internet access, we have a tablet program where we've downloaded videos that may be useful for nurses to then share with family members about, and so we're sending them to the Canadian Virtual Hospice site about how to turn a patient and things like that. And we have all of that downloaded on these tablets. Our partners are the regional health authorities, and a couple of them have actually used tablets where they give them to the patients on their palliative care caseload so that they can communicate with them through video contact. So again, that works in the areas where there is internet, but and they loan out the iPad to help with that.
Thank you, Sue, for sharing.
I can just add one other thing. So it's not something that we're doing specifically in First Nations Health Authority, but one of our regional health authorities developed a tool for how to discharge better back to First Nations communities. And some of our regional health authorities also have a map that they click on. So if they're going back to this nation, so this is on their internal website, and they click on and it tells them what the FTE of the nurse is and who they contact. And it's usually a phone number rather than an email address, so people are aware of how to do that better. But having said that, sometimes people are still sent home and there's no communication to the nurses and community. They're just arrived and the family member says they're home. Yeah. But I can connect with you afterwards and give you that tool.
Thank you very much.
Excellent. One connection made here. Let's give a round of applause for that connection. That's what we're doing here, people. Okay, Jilly.
So as we get queued up for the third question, though, I also want to go back to something Marjorie was saying, and for those of us who were here yesterday and we were listening to Diane talk about the death doula program that she has in her community, I think, and she's certainly receptive. I spoke to her yesterday. I mean, that's really about how do we enhance the capacity within the family to support people with a serious illness. And she's a great connection for any of us to probably connect to and learn more about that program. So our third question is, back to Menti, what can you do right now that will improve the care of Indigenous people who are journeying back to the spirit world? And again, this is looking at education and training in the community that you think we could do right now. So keeping in mind, where do we want to be going next with this? What are the types of things that need to happen? Sue, you just happened to mention those that maybe are from the training, maybe focusing on policy or go into that kind of political sphere. Maybe there's something in there. And what are the types of recommendations that you have?
So I think we're having a little bit of technical difficulty. So when you guys are clicking on the QR code, is anything coming up for you guys? Okay, there we go. Good job. Sorry about that, guys. Never said I was tech savvy. Okay, so what we're looking for here, everyone, in person and online, what are one or two things that you are going to walk away from this session with? So, Natalie, your answer, you are going to connect with Nicole over here at the First Nations Health Authority. You're going to make that connection. That's one tangible thing you're walking away with. What else? What else are you guys going to do that's going to improve the care in terms of education? Who are you going to reach out to? Who are you going to follow up with? What booths are you going to go and see here at the conference? What websites are you going to go? Who are you going to advocate to address some of these challenges? How are you going to build upon your strengths? So we're looking at one or two tangible things or a recommendation that you have.
And online from the Menti responses, we've got training for caregivers on medications and administration of medications, subcutaneous, I'm thinking training around maybe, etc. Designating a specific care team, for example, specific people. Education on anticipatory grief. Providing more care and supports for caregivers and more advocacy for grief work across the lifespan. paying elders and knowledge keepers for their support or involvement. How to get more trainers in the community, teaching various education sessions, providing, that's the first time it's come up actually, is the trauma-informed culturally safe care, advanced care planning at diagnosis and to train the family, making those connections in every province and territory to adapt the training, ask communities what they want for education. Again, more advocacy or education around grief and loss across the life cycle, the sharing of resources, follow up on educational resources that we're seeing today, sharing current resources from the exhibitors and available palliative care training, or training that's available, gaining access to training in palliative care and end-of-life support. We've got one that you can go to the Canadian Virtual Hospice Learning Hub.ca for the Indigenous Cultural Safety Training, including grief support. That's another area of the Canadian Virtual Hospice that has a number of resources and a portal that's available and is free. Encouraging family members to train in palliative care, especially pain management in the absence of healthcare workers. And then building community-specific end-of-life guidelines after consulting elders and knowledge keeper, and increasing our hospice spaces within community. So those were the questions online. So now I'd like to go to our panelists. And what are some of the...
Oh, there's a couple of more. Sharing Spa LTC. That's for the long-term care project. They have a booth out there. Dr. Mary Lou Kelly's in the room. We should give a shout out to Mary Lou. Secure funding, improve resources. I just got to say, miigwech each and every one of you for joining us on this venture of Menti, and for those of the people that are online. Whew, it worked. I'm so relieved. My team and I have been thinking about this and trying to figure out how we're going to engage with people online and in the room at the same time. So first off, big round of applause to all you guys.
For everyone.
Okay, now what's your recommendations, ladies?
I was thinking, communication is the key to a lot of our ways of knowing, and incorporating our sacred language keepers and involving them in the process, because, I've witnessed a lot of our people diverting back to our language when they're on their final journey, and having that ability to have that translator or that connection between, the family, the person, and the ancestors would be really helpful, and changing some of the criteria and making it language appropriate in each region, because we're so diverse, right? So that might be something that we could think about.
Thank you, Joanne. Yes.
That's a great recommendation, Joanne. Yeah. Anything, Sue?
I was going to say, Joe has a long wish list here. I think for me, I feel more committed to two things that have been on my back burner. One is to provide more education around funeral planning, so that can be a safer experience for First Nations people and help them to be able to bring it back to their communities. And two, about wills. Supporting the completion of wills and education around that. So I feel more committed to some of these other areas.
Great.
So I would say for myself, one tangible recommendation or follow-up that I'm going to have is the lovely lady in the front who is from the Northwest Territories, who's really interested in bringing two lovely ladies in the front row from the Northwest Territories who are interested in bringing our education up to the Northwest Territories. And as I was telling her over break, we actually were in Fort Smith delivering our palliative care education quite a few years ago. Lovely country. The Northern Lights were out of this world. Would love to come back and do some work with the Dene. So again, let's make that connection. Definitely. Anybody online? Who are people online? Do you guys got some tangible stuff that you guys are going to do following this? Any follow-ups, any connections, any recommendations that you have? Those poor people online, they probably get all nervous every time we go back to the Zoom poll, because they're like, please, Holly, don't call upon me. We've got to win this challenge.
If we can get one person online, at least then we've had one for every question we've
I know,
asked.
one person online.
One person online with a recommendation or strategy that you're coming away from or with today.
Take yourself off mute. Take the chance.
Or put it in the chat. If you're too shy to come off mute, you can put it in the chat as well.
Oh, Kevin.
Share your passion with one more person.
Oh, great job,
Great.
Kevin.
Thank you, Kevin. Yes.
Great job.
And in the room. Yes.
Oh, we need some mic, guys.
That's on? Yeah, thanks. Phil, psychologist, ally with Muskeg Lake Cree Nation. One of my thoughts is that even in some of the Western programs and ideas in terms of palliative care hospice, that grief and loss and bereavement has often been the poor cousin and not gotten even as much of the sort of internal funding that, say, a palliative care program may get. And that even though our focus in this gathering is the journey of the seriously ill, of those seriously ill, that I'm also thinking about the forgotten mourners, those often forgotten, and that the natural pathway in many communities actually to grief and loss resources and knowledge of different types is a palliative care or hospice circle. There may be nothing else that exists, say, in the mental health structure that addresses grief and loss. And so it being the natural pathway, the learnings and the resources that could be also shared with those whose, the families of and friends of those whose physical lives have ended suddenly, tragically, without a journey necessarily that's been known. And you know, so much of the expertise is there, and to sort of extend it beyond the hospice palliative care family to the larger family. And also a shout out to Shelley that Shelley didn't mention, another initiative on the part of Canadian Virtual Hospice and herself and Paul Adams and other colleagues is that they've served as the catalyst for a larger network, which is the Canadian Grief Alliance. And the Children's Grief Alliance is also part of that. So networks having formed in the not so recent past of people talking to one another across the island, across the land.
Yeah, I think that's great, and I just want to add one more thing before we conclude. Is just there's a lot of things out there, and I hope that this session has highlighted some of these pathways to education, the amazing thing that the First Nations Health Authority is doing, Pallium Canada is doing, the stuff at our center is doing, McMaster University, and the Canadian Virtual Hospice. For those of you who do not know about the Canadian Virtual Hospice, please Google it. Come and check out our resources.
We have their booth is here.
They have a booth here. We have a whole repository of livingmyculture.ca, which are specific resources for First Nations, Inuit, and Métis communities and peoples. And 1,200 stories. There was a lot of stories we went across Canada to collect. So miigwech for that.
Yeah. Great. Well, we're out time for lunch, which again is going to be in the foyer. So we're going to be breaking and then coming back. I think it's at 1 o'clock into the next sessions.
1:15.
Which now that you've gone through this morning session and the feedback session, this is also a similar venue that we're using in the afternoon. So the sessions that you go to, the panelists will talk about and give you an overview of the topic, and then we're going to come back and do this type of a session after that.
So you guys have 3 sessions again to choose. Pick which one that you're most interested in. We're going to be in C and D, which is the large room that we were in for lunch. The lunch is going to start right at 12. There's some really amazing panel discussions that are going to happen in the large room at 12:30. We have 12:30. Is that you, Mary Lou? Are you on at 12:30? Oh, 3:45. Okay, so we're going to have a couple of panel presentations. I think the Indigenous Nurses Association is going to be up there. We have some folks from Accreditation Canada that's going to be talking about some of those things. So just some light listening over eating. You know, that's how we roll.
If you haven't checked out the vendors that are here, please do. They've got some beautiful...
Support local Indigenous peoples, crafting. It's amazing and really great stuff out there.
And thank you to our panelists again for your time and your sharing. And to our participants online and those of you in the room for sharing, thank you.